everyone, and welcome to the United Creed podcast. We've got a very special guest today, Dr. Luis Rodriguez. He is special because he's been treating me for almost 5 years now, and he's got a wealth of knowledge. He's been practicing. He's an expert in the field of oncology, and he's been practicing for over 2 decades now. And so he comes with a wealth of knowledge, and before him, his dad practiced in oncology as well for decades. So he comes with a lot of experience, a lot of knowledge, and we've developed a great relationship over the past 5 years. And I can say confidently that Dr. Rodriguez's work is a big part of why I'm still here today. So it's an absolute pleasure to have you today. Thanks for coming on the podcast.
Thanks, Justin. Happy to be here. This is great.
We really do appreciate it. So let's tell our listeners a little bit just about yourself. Like, how'd you grow up? Where'd you study? And kind of what inspired you to become an oncologist?
Yeah. Well, my dad was an oncologist, but growing up, I didn't really understand a whole lot about what that meant. I grew up in San Antonio and finished high school here, and I liked the sciences, but I went to University of Michigan undergrad thinking, I think I'm going to be a businessman, an economist, something non-scientific. And while I was there, I realized I didn't really like that stuff as much as I thought, and I fell back to chemistry and biology and started realizing, medicine kind of has something there that I might be interested in.
Yeah.
And so thinking back about what my dad did and putting those things together and meeting other students, I figured medicine was the way I wanted to go. So I did a little bit of research in undergrad, ended up graduating and then getting into med school here in San Antonio.
Yeah. So
I came back to San Antonio and finished 4 years of medical school and really didn't know for sure I was going to do oncology even then. I knew I wasn't going to be a surgeon. And so I narrowed things down to internal medicine and then went to WashU at the Siteman Cancer, or at Barnes Jewish Hospital actually, for residency. And in my second year, I thought I'd be a gastroenterologist. And I realized I wasn't a procedural type of guy. I wasn't going to be doing scopes.
Right.
So I decided to fall back into real traditional medicine with oncology. And at the time, this was in the 90s, new drugs were being developed that were making headlines essentially because they were different than chemotherapy. So that piqued my interest. And then I stayed at WashU for my fellowship.
Right.
And that finished in 2003. And then I came back down to San Antonio to practice initially with my dad, which was great. He had been practicing since the late 60s, really when oncology started.
Right.
As its own specialty. And so then he wanted to retire, and I ended up joining with the big group that I'm with now at the Start Center.
Yeah.
So,
love the Start Center. Well, we're definitely glad you answered the call.
Thanks.
It's quite a journey, though. It's really always interesting to hear how that inspiration happens. And I know that your dad was a big part of it too, and it's so great that y'all got to spend that time together.
It really
from
was.
One generation to the next.
Yeah.
I mean, front to back. That's
for
powerful.
me. That's an extreme memory. It's a happy memory of being with him in the office, both in our white coats, and he was teaching me stuff. I mean, you don't leave your fellowship knowing everything,
right?
But I taught him some things too because
I
was up to date on the drugs and the newer kind of things. So we complemented each other and. He was 70 when he retired, so he had a long career, and I'll get there.
Yeah, of course. You will, I have no doubt. So, yeah, I guess let's go back to when you and I first met, right? That was in, I think, July of 2020. I had surgery earlier that month and had a successful surgery, removed my right kidney. We knew at that point that the scan said there was a pretty good sized lesion in there and it was likely cancer. So we removed it. You got a pathology report and we met each other for the first time. And, the pathology report said that it was collecting duct carcinoma, which is, I'll let you talk more about that. But, and then you also had to tell me, and your lymph nodes are pretty swollen and there's a pretty good chance that that's probably cancer too. Yeah. So, talk to us a little bit about what collecting duct carcinoma is and what's like the general prognosis when it's reached that advanced stage that it was in.
So you were referred to me, and this is the way it happens. Doctors don't know who they're going to meet when they walk in the door,
Right.
And patients don't know who they're going to meet oftentimes either. But I see a young guy who has a young family, and I see a rare tumor that, quite frankly, represents 1% of all the kidney cancers out there.
Yeah.
So we talked a little bit about that, right?
Yeah.
And I told you my concerns.
Yes.
That the rarity brings in, the need to consider second opinion at a high volume center, and that with your young age, and I think that you probably brought it up before I did, we could be aggressive.
Right.
And collecting duct tumors, as rare as they are, we know a little bit about them because there's a spectrum of reports that describe what they behave like. And just to clarify, most kidney cancers are called clear cell carcinomas.
Right.
And then there's various subsets of that. And there are various genetic disorders that we can, mention there. But for collecting duct carcinoma, it's just one of the more rare ones. And it can behave quite aggressively. No clue how long you had it, right? We talked a little bit about that. Everybody wonders, how long's this thing been in me?
Exactly.
And you just presented with symptoms all in a matter of a few weeks.
Mm-hmm.
So the plan at that time really was to explain to you those nuances, and try to get a plan. Try to get a plan for you that probably included more surgery, but we weren't sure.
Right.
And then we talked about what other treatment after that. So then, from there, I think you pursued quite a few things that we can talk about over time.
Yeah.
But that initial encounter, telling you what I thought, and you telling me what you wanted is important, right?
Exactly.
That's the way it should be.
I agree. Yeah, and that level of respect is important, I feel like, for a patient-doctor relationship,
Mm-hmm.
and especially in this kind of a environment, right, where like it's so rare, and it's like, there's no real good answer on this one.
Yeah.
It's kind of like we're working with the best that we can, but we're kind of in the dark a little bit.
That's
you
right.
know?
Yeah.
But that whole, like, seeing that whole exchange, that first meeting that we had, in hindsight, it helps me understand that, you're a doctor, right? Like, you're in this big place of power, but you're also just a human, that you've got to come in and deliver awful news to people like every day of your life. Like, you have to do that. And that just really made me wonder, like, how do you do that? What are you taught anything in medical school? Or are there things that you intentionally do personally to help shield yourself from the emotional, spiritual challenges that come with that role?
You do learn a little bit. Some of it is perhaps your natural disposition about comfort with talking about serious things. When a patient has come to me, or I'm asked to go see a patient, they either know already a little bit, but they don't know the full story about what their prognosis may be, and even their stage sometimes they don't understand. So those conversations, you have to prepare for them emotionally. You have to kind of reserve your emotions, because that's not really your department. You have to be objective enough but sincere enough to explain something that's very serious. My nurse has told me, she said, the tone by which a doctor talks, the mannerisms all matter.
Yes.
Sitting down, not standing up, not looking like you're rushed, and asking the patient a few questions. Those things, that interplay matters. I had some good colleagues that I trained with. And when you get training at a high volume cancer center with experts, you get to see all the different styles of delivering bad news and good news.
That's great.
And so that's one of the reasons it takes years. It's not just learning data.
Right.
It's that human interaction that's part of it.
Yes.
So some people do it better than others, but it's all meant to be, obviously, with care.
Right.
And so there are days I break down.
I'm sure.
There are days where I don't want to go in the room because I know it's going to be a bad interaction. It's going to be a sad interaction.
Yeah.
But you push forward with it because that's your job.
Right.
And you got to go in with a plan.
Yes.
That plan may change in the room. You know,
Yeah.
you may have an idea what that patient will accept or what they want to do, and then they give you feedback and say, I'm not willing to do that, or
Right.
is that all I can do? Can I do more? And then you talk about a plan. So it's preparation, and then when you leave, you feel like you've done what you needed to do, and hopefully, you know, there's better days.
Exactly.
Yeah.
And that kind of leads into a question that I've always had too is like, I realize being a cancer patient myself that your oncologist, like what they say has a massive influence on the hope that you maintain and the, you know, the like inspiration to like keep fighting for life. Like the oncologist has a lot of influence over that.
Yeah.
So like you've kind of explained some of the tactics and things, but is there anything that they kind of coach you up with to walk that line? Like, you know, preserve hope as much as you can, but be objective.
Sure.
Like tell them how it is, you know?
Becomes a fine line. I know that there are studies that have looked at, you know, what does a patient hear relative to what does a physician say?
Yes.
Not just in
yes.
oncology, but with all the kind of different interactions, whether it's a cardiologist or a neurologist. And patients are getting information that they're filtering immediately.
Right.
So sometimes, quite frankly, it takes multiple interactions to figure out what is the right, are they understanding things? What is the right way to kind of make sure that the plan is understood and to keep that hope?
Right.
The good thing is that for most early stage cancers, patients are going to be cured with surgery and whatever else we do. Most early stage cancers will be cured in this country. And that is something that you can tell a patient with good objectivity, you know, you have a 70, 80, 90% chance of being cured in this stage, et cetera.
Right.
And that brings a lot of hope to them. Of course, they're still scared. What you don't know ahead of time is who is in that 70, 80, 90% group.
Right.
And so, you know, you always have to balance that these treatments may not work, but if they don't, we're going to try something else. So I think those conversations are not too difficult, but it depends on how those questions go around that.
Yeah.
And hope is important. You don't want to mislead anybody, but
Exactly.
you know, keeping them informed about findings and opportunity is important. Yeah.
Yeah, absolutely. That's quite a dance, right?
Yes.
Because you don't want to give false hope.
Yeah.
Right. But at the same time, you want to inspire them to, hey man, we can keep going here. Like this fight isn't over, you know?
And one of the worst things is if somebody comes in with an absolute preconceived notion that they're going to die when they're not going to die.
Yeah.
You know, they've talked to somebody, they've seen another person go through something, and they're making an association with what they've seen or heard that doesn't apply to them, and you've got to break that down to really make sure that they're not confusing things.
Absolutely. I know that when I was hit with all that news, like so many things swirl in and so many people telling you certain things, and that's why I think it's really important to have a good relationship with your oncologist, to really trust, you know, that trust. That's something that I want to talk about today, because I think you face a lot of headwinds with trust. I mean, I have no doubt that most doctors are in this thing for the right reason. You know, they want to make a positive impact. They view their profession as a way they can serve others. And that's like virtuous, and it, you know, provides purpose in their life. Like they're in it for the right reasons. But then you've got, you know, these really big pharmaceutical corporations that have earned a reputation of getting filthy rich off of people's suffering. I mean, it really took off in like the 90s, early 2000s with the opioid deal, spiraling completely out of control. So I feel like right now in the cancer community, a lot of people bring their oncologist into that. You know, they're like, you associate with these big pharma guys, right? And you're just one of those guys, you know, that is all in it for the money kind of thing. So you face a lot of headwinds with that, you know, like the relationship is kind of tilted in a bad direction in many cases to begin with. Can be. So like, what are the key things that you try to do to really lean into trust, to really, you know, convey that you're you're in this for the right reasons. You've got their best interest at heart. And, how do you kind of overcome those headwinds that you're faced with?
So oncology as a niche within the bigger picture of medicine, there's an enormous amount of trust that does come from patients automatically, and that is super helpful. In terms of explaining, the medicine is expensive in the U.S. Drugs are expensive. The care around the board is expensive.
Yes.
And I think that a lot of people, when they see deductibles and copays, they're amazed, right? When you get really sick and it potentially becomes a chronic year-over-year thing, it's really a financial burden. In terms of the physicians, I think that fortunately we're thought of as above that kind of collusion or whatever you want to call it, where somebody's just doing something for money.
Right.
To defend, sort of the pharmaceutical side, at least within oncology, you really have people that want to cure cancer.
Yes.
They want to create a disease that might be fatal into something that people can live with much, much longer.
Yes.
Ideally with a cure, but sometimes converting a deadly disease to something that you can live with for decades as a chronic disease is the best you're going to get at the moment. So for patients that need the reassurance, there's a couple things. One is I like to tell them that we have clinical trials that show the efficacy of a drug.
Right.
So this is the kind of cancer that you have. This is where the drug was studied, and this is why we use it. We have guidelines that are set up by non-pharma, experts in the United States and internationally that compile data on different disease states and which drugs will be most effective, which ones will be least effective.
Right.
So the bottom line is that if they don't trust you because they're focused on something outside of what you can control, that's too bad.
Yeah.
But most people, fortunately, aren't going to do that.
Yes.
And I think that the oncology wins that we've seen in terms of new drug development speak for itself.
Yes. I definitely
as you
can speak
attest
to
to
that. Absolutely. Yeah. Some of the things we'll get to later, but some of the things that I took or I am taking, they weren't even available whenever my journey started. So I can definitely testify to that. There is a big effort to cure this thing. There really is a lot of work going into that.
Yeah, the new drug development is incredibly robust, and even in San Antonio, we have 3 institutions that do major drug research, and the cancer patients in our community have access to that. All over Texas, there's other institutions as well, but that's, and that takes trust, right? For a patient to say, I'm going to go on a study of a drug that is being developed, and that's an incredible amount of bravery for a patient to do. And I think they get that trust from the doctor who says, I really think you should do this.
Right.
So that's a relationship. That's another thing that's just built up over time. And hopefully people can see that.
Yeah. So let's talk a little bit about, you talked about you got to have a plan, right? When you're going in to talk to these people. I feel like there has to be, that is, you're talking life and death here. You're making really big decisions. So I've always just been curious as a patient, what are the levers you're moving? What are the key drivers in that plan that you're developing?
So as an example, in your case, do you understand the pathology? The pathology is the tissue type, right? What kind of cancer is this? And you got to be sure you know what it is.
Right.
Some cancers have nuances where they behave as more than one thing. But the first plan is understand the tumor type.
Yeah.
Understand the stage, get the data that you need, look at somebody's blood work, scans if needed. But you've got to put a lot of pieces together in order to really come up with a plan. And that'll include patient preference. That'll include understanding what a patient's other disease problems are, because those could cause limitations. But the main way that we choose therapy and walk into a room and say, here's what I think is best, is based on clinical trials.
Yeah.
and it's based on, some guidelines which kind of filter those things. But yeah, I would say it's that combination.
Right.
So
Absolutely. Yeah. I think, that's one of the reasons people flock to the States is because we have such a well-tested clinical trial. We have a formula that has proven to work, right?
Yeah.
And it's really good to peek behind the curtain and kind of see how you guys are sifting through this information, because it
Yeah.
is, it's just, I don't envy you, you know?
Well, it's a lot of information that comes out, but it's over an extended period of time. And so once you build a base, right? Once you've done your training and you've been in practice for a while, the new drugs as they come out, they're just an excitement.
Yes.
It's like having a new tool. And you don't have to learn a whole lot, because other than absolutely new class of drugs, there are a lot of copies of each other, but they're just getting better.
Right.
It's kind of like the faster car or the more safe car.
Yes.
It's still a car. You know how to use it, but there are other features with it that make it better. And so drug development is heading in that direction, which is nice. But there's a lot of information that comes out in any 1 month.
Right.
That could be life-changing for a patient.
Absolutely. And that's even more to this point too. Like, there's becoming more options on the table, which is just an awesome thing. Like, it really is.
Yeah.
But it puts a lot of pressure on the patient, right? Like, am I making the right choice?
Yeah.
Like, am I, like, that's tough stuff. And I have found something that's called freedom prayer that really helps me with that. It's kind of like a way to reflect and meditate and, use scripture to guide your thoughts, like prayer, right? Like,
Sure.
my approach to this thing was, let me hear what all the experts are saying. Let's hear what the oncologist says. Let's hear what a surgeon says. Let's hear what unconventional, folks say. And then I'm going to sit down and I'm going to take it to God, and I'm going to pray, and I'm going to ask for guidance, and I'm going to really reflect and, spend some time deciding what I'm going to do next. Right.
Right.
I know that that's not part of the MD playbook, but just you as a person, do you feel like that's important for a patient to do? Like, absorb the information and then take a pause to really reflect and think through everything.
Absolutely. I remember you specifically telling me on a couple of different occasions that we were just both trying to decide what would be best for you. Is I've prayed about it.
Yeah.
And you move forward based on the totality of what you felt was good for you. And that is not uncommon. There are a lot of patients that will tell me that they have prayed about something, they have talked to their family, they have talked to other people, and that's great. If it brings clarity, that's important. I think what's also important is that they listened to me.
Yes.
That they understood why I had a rationale for a plan, even if they choose not to do it.
Yeah.
Because you don't want to have no information with which to go on, and very biased information with which to go on. You want to be able to receive all the information and then make a decision. So that makes perfect sense to me.
Yeah.
The range of interactions that we see, I mean, you can imagine it's I'll do anything you say, which may sound easy, but it's very robotic.
Yeah.
And you kind of wonder sometimes, do they really understand?
Right.
And then there's the person who says, I don't want any of this, and they literally will never come back. And they will do something that is not within, the Western medicine, let's say.
Right.
But I have respect for people's decisions. I only see adults. I don't see kids.
Right.
So I do feel like if I've had a conversation with somebody and they've listened to me and I've listened to them, we are going to make a decision that will be okay.
Right.
Yeah.
So what do you do whenever you have some rebel patients that kind of go a different path sometimes? Like, how do you handle those situations?
Well, you have firsthand knowledge of that. You and I wouldn't say butted heads, right? We used our heads.
Yeah, yeah.
So you had a lot of good questions for me. Well, why should I do this as opposed to that? What is the downside for me to do this versus that? Yeah. What about reversing the sequence of things when we talked about, and the reality was, as you remember, I didn't always know if what I was telling you was going to be the right thing.
Of course.
And I told you that. So I think this is the next best step, but we've got to choose. We've got to make a
Yes.
decision. So most of the time it happens that way, that people will just interact and agree, with me or with their physician.
Right.
To really make sure somebody understands what I'm trying to say, I do sometimes say, you need to go get a second opinion.
Yeah.
Before you decline, before you decide to do something else, can I set you up with somebody else? Because sometimes just hearing it from another person, it registers.
Yes.
Taking time to absorb things. There's very few things in oncology where you got to make a decision that day.
Right. Of
Right.
course.
So you usually have days, a week or two, to put your thoughts together, get more information, and perhaps get a second opinion. But I don't mind the rebel in the sense of questioning. What else can I do? Or I'm thinking about doing this. We just talk about it.
Yeah.
It takes time though.
Right.
And so sometimes those require multiple visits to figure out what really is going to happen, what they're really getting at.
Absolutely. I think that's well said. And I think that is such an important part of that, finding the right doctor is, finding someone that will work with you
Sure.
and really does try to put themselves in your shoes and then do what you'd want, be golden, right? Like
Right.
treat them the way that you'd want to be treated in their situation.
Yeah.
So I definitely respect that.
Yeah, and we get asked sometimes, what would you do?
Yeah,
Right?
exactly.
Turn it around on you, doctor. What would you do? And my answer is, I'm telling you what I would do. I don't treat you differently than I would myself. I don't treat you differently than I would my father or my mother or my sister, etc.
Yeah.
But there has to be something that lets the patient decide.
Yes.
And you and I had plenty of those interactions where essentially you made the decisions.
I did. Yeah.
I mean, that's the way it fell out.
Yeah. Yeah. And that, getting back to my case, I had the surgery like we talked about to remove the kidney. And then, we talked and you said, you know what, I think in this case, given the rarity of the tumor, it's a good idea to get a second opinion. So I went out to MD Anderson, which is supposed to be one of the greatest in the world, and all the reviews, and they definitely have it down, I'll say, from my experiences. But, they took a sample of the tumor tissue and did they had their entire pathology panel look at it. And then it kind of left us with a little more uncertainty. They were like, I don't think you have collecting ducts. It doesn't really tick off all the criteria.
Yeah.
And ultimately they said, it's just, we're just going to call it unclassified.
Yeah, an unclassified with biphasic features, which I'd never seen written before.
And what does that mean?
Well,
in
it
layman's
had
terms?
features that overlapped two different areas of the kidney in terms of etiology, where in the kidney it would come from. But it was not marking as the most common thing that we call clear cell carcinoma.
Yes.
Or it wasn't marking as a medullary or a papillary in the more common things. So it had features that made it hard to classify.
Yes.
But clearly was of the kidney.
Yes.
Which was important, right? It
course.
didn't spread to the kidney; it was from the kidney. But you saw one of the experts there that made some recommendations. And again, if you read the note, it says there's a rarity of information,
Yes.
and that this is typically an aggressive tumor.
Yes. Yeah.
And then things took off.
And that's where we were. That the expert at MD Anderson, because it was so rare and because he was like, I don't want to give you anything because I don't know how this would respond to the chemo. I don't know how this would respond to immunotherapies. That was really all we had at that time, And he was like, I recommend that we just have surgery. And we removed those lymph nodes.
Right.
And they took out 32 in the retroperitoneal region, and
Right.
there was cancer in 7 of them.
Yes.
And we just watched it for 9 months.
Right.
And
I think you were on an every 3-month scans.
Yeah.
And then something showed up.
Yeah, it was 9 months, and then something showed up on the liver, which in hindsight, it may have really been on the diaphragm.
Right.
Because that's whenever, the expert at MD Anderson had said, like, well, before all of this, he said, let's have surgery and let's see, how it goes. Maybe we can learn some more and really get a clear prescriptive path. And we never really learned anything. He did ship it off to Elizabeth Perlman, maybe is.
I don't remember.
She's in Chicago. She's supposed to
I know several pathologists look at it.
Yeah,
And they also did molecular testing, right? So at the time, I think the gene panel was 163 or something like that genes, looking for more information. Not only for just classification, but even more so for future therapies.
Right.
And that came up kind of empty.
It did, yeah. So we were in complete remission for 9 months, but we never learned anything more, really.
Correct.
And then it came back, and it was like, hey, it's stage 4 now. Like, this is pretty serious stuff. And so he said, before, he didn't want to give me those because they could, quote, kill me faster, And so I didn't really feel comfortable diving into that.
Sure.
Right. And that's whenever we really took some pause and tried some things, some stem cell and oxygen that, there was no oncologist unstaffed in that situation. And while I think it's a great thing, stem cells and oxygen, I don't think that it really fixed my problem, obviously.
Well, I remember you came to the office after the news from MD Anderson that they were recommending chemotherapy. And that was a point at which, I was listening to you.
Yeah.
And I couldn't give you a definitive, don't do that, definitely do this.
Yes.
And so with your choice to try the non-chemotherapy route, we agreed you'd be monitored closely.
Right.
And that you wouldn't just disappear for a year.
Exactly. That was,
and that we would get scans and make sure that things weren't going to take off and really get you into trouble if it wasn't working.
Absolutely. Yeah. And I've really appreciated that support because that's, dealing again with the rarity of it. I was trying to find my way, and I learned a lot along the way. I definitely recommend, if patients want to go outside of conventional, like, make sure there's an oncologist on staff.
Sure.
That really helps validate, I think, the treatment. But we did that, and then that doctor that I tried that experimental thing with was out of Chicago, and ultimately he introduced me to a surgeon.
Right.
And so I elected to have that surgery. And while all of that was playing out, we had found a collecting duct carcinoma group on Facebook. And my wife found a man named Scott Schaefer. He was a patient, collecting duct patient, had some success with immunotherapies.
Right.
So you were like, go talk to his doctor and learn more. And
up at Penn State or
Dr. Yoshi.
Yoshi.
And you guys collaborated, and she kind of shared what she had done with Scott, and you were like, hey, I think it's a great option.
Yeah.
And we did it, and it worked really well. For 9 months, I was in complete remission after they removed 75% of the right diaphragm and like probably about 5% of the liver, got on the immunotherapies. It was really great for 9 months. We had like no evidence of disease.
And I think that's right around the time when we started monitoring the DNA in the blood.
Yes,
with Signatera, maybe a little bit before that.
Right.
And that's how we were able to know, not just on x-rays, but with the blood work, that we had something working pretty quickly.
Yeah. So tell us a little bit about how that works, the immunotherapy. It's newer,
sure.
But
yeah.
Yeah.
So when I was in training, nobody wanted to give immunotherapy because at the time it was very nonspecific and very toxic.
Yeah.
And so this was developed, 80s and 90s. Coming to the 2000s, monoclonal antibodies were developed that could, these are basically proteins that would bind to certain tissues and affect those tissues. And in this case, immunotherapy stimulates T cells and natural killer cells to re-recognize abnormal cells,
right,
and get rid of them. So it puts them back in the responsibility that they were made for in the first place.
Right.
So you had a dual therapy. You had Yervoy with Opdivo,
right,
which was an aggressive immunotherapy regimen, and it worked. There were some side effects.
Yeah, there was.
But to see that happen and to know that you can engage the immune system in that way, that's where we're going still. We're just trying to refine, getting those cells to focus only on tumor and
right,
not on anything else, and combating some of the side effects that come with immune therapy. But basically, immune therapy is activating the immune system to go damage and kill those cancer cells.
And how long has that been around now?
Really, in this proper form that we're using now, 15 years
Right.
or so.
It's newish.
Yeah, it's newish. Yervoy was the CTLA-4 antibody, and then came Keytruda,
Yes.
and later Opdivo and some of the others that are, again, similar, but they're all structurally a little bit different. That's why they're approved differently. And in kidney cancer, it raised the cure rates for non-collecting duct, but for clear cell, it raised the cure rates from 2-3% to 8-10% in stage 4 disease.
Yeah, that's big.
And then other drugs came along, which we can talk about. But that was our initial approach for you, was based on the expert at Penn to give it a try, even though it was a rare tumor.
Yes.
And there's no playbook.
Exactly.
This is not guidelines.
Right.
This is stuff that you just do because there's some science,
Right.
and then there's some experience.
Exactly.
And that's,
Yeah,
so-
that was kind of a one-off scenario,
Yeah.
but in my position where it's like I've had experts say, like, I don't know how this stuff is going to react.
Right.
That felt like the right move to make. And so it worked really well. I was in complete remission for quite a while. And then we had another, it reared its ugly head again. And at that point we had to sit down again because, I was still of the opinion that, I don't think I should do the chemo yet. Right.
Right.
So and then you were really a great, I don't know what the right word is, but you really let me know, like, hey, I would not do surgery right now because we're at the stage 4 mark now. There's probably disease in there that we can't really see yet. And, why don't we treat it with medicine, kind of let's see if it stays stable, or if anything else comes up, we can still have surgery, but let's wait a little while. Right.
Yeah.
And then ultimately I had my time to reflect and make the decision. And I made the decision to go ahead and have the surgery and then debulk, get it all out of there, and then try something new. And we did, and you were right, because I had the surgery, and then right after it, there was already tumor on the liver, right away. So we went back and brought the Yervoy back in, and then we introduced Cabometyx.
Right.
And that works really well too.
Yes.
It took me from, we could see on the tumor marker Signatera test that it was going down and shrinking. And I had some side effects, that kind of took me out of that treatment, but it worked really well.
Yeah.
So can you talk a little bit about what Cabometyx is and how that works?
Yeah. So Cabometyx is a small molecule drug. It's a chemical that we call a tyrosine kinase inhibitor, a TKI. And basically it binds to certain receptors in the body and shuts down growth signals and shuts down pathways that the tumor is using. Cabometyx is an earlier generation, so to speak, of this kind of drug that hits multiple different targets. The main one is VEGF, which is vascular endothelial growth factor. And then there are others, and that's where the side effects come in. Yeah. So because you're hitting multiple targets, theoretically, that's multiple chances to injure the cancer.
Yes.
But it's also hitting normal cells and causing some side effects.
Right.
But it was approved based on its efficacy. And we just extrapolated again into collecting duct and showed that it did work.
Yeah.
So, the main side effects aren't that bad, but high blood pressure and fatigue,
yes,
diarrhea, and
absolutely,
skin problems. So, those aren't trivial. If you're working, like you did for much of the time that you were under treatment, trying to continue to work and be with your family, those are interruptions that you have to take into account.
Absolutely. Yeah, it was, like I say, very effective.
Yeah.
I mean, immediately it started to produce results. And it worked well. And then I had, a little bit of bleeding episode that took me...
A little bit.
Yeah, exactly. That was a close call, we'll say. And, I wasn't doing ourselves any favors. I was so stubborn, I was in a lot of pain, and I wasn't telling you, which was a big mistake. and I was just trying to medicate, I was taking Tylenol, and in between Tylenol doses, I was taking ibuprofen,
Right.
which just like, it was like pouring gasoline on a fire, and the bleeding got severe, and I was in the hospital for like 2 weeks or so. And, but we came out on top, and then 2 months later, the cancer came back again.
Yeah.
And that was the big like moment for me, is like, okay, like we got to get real serious about this. And my body now is probably not fit to do something really extreme like chemo right away. And so, I did some praying and talking to all kinds of different people, right? And ultimately found a newer type of way to leverage the immune system
Right.
that's in clinical trial.
Yeah.
And went and did that. And right when I started doing it, the tumor markers went up really high.
Yeah.
And the disease, there was evidence of disease, like big time, up in the chest, and even like in the diaphragm area. And so that was a big moment for me. The doctor that started that, I understand his position completely, that the way that treatment works is they're training the dendritic cell to recognize and engage.
Right.
And when that happens, the thought is that it's going to find that disease that's in there that you can't even see yet, and it's going to start to kill it, right? And when that happens, there's a good chance that it can swell up and die off and cause spikes. But mine was really high, and it had tried to take off on us before. So that's where, you were like, hey, we need to do this. Like, we need to do this. And that's when we hit it with the carboplatin and the Taxol.
Yeah.
And just after one round of that, it went from the tumor marker at like 1,570 to below 50.
Right.
And you called me up, and I think your exact words were, I think we may have turned the freight train around. And I was like, yes, man. Like, that's whenever I really did start to believe that, what I did with you, and I think that what I did with him too had some a part of that, right?
Sure.
Like, I think that it worked very well, obviously. We'll never know what would happen if I would have said, no, I'm not going to do the chemo.
There isn't two of you. We couldn't split you up.
All I know is that I'm glad I said yes.
Sure. I remember that. So you were sick in the hospital, very frightening. We talked about, the reason you made it through that is that you're young.
Yeah.
Older person might not have made it. So rare complication of medication, but you made it. And then we were keeping chemo in the back pocket.
Yes.
Mainly, for the reasons that chemotherapy does have toxicity, and there's quality of life considerations, and you had things that you were doing. But you had one more surgery.
Yeah.
Up in Illinois.
Yeah.
To get tissue to get ready for the dendritic cell treatment, right?
Yeah.
And I remember that. And again, that was where we talked about it, and the thought was just we'll keep track of it. We'll stay on top of it.
Yeah.
And if things take off, we'll have a backup plan. And I was fine with that. When you came back and I think you'd had 3 infusions. And then you came back and we did that first set of scans.
Yeah.
We weren't sure what was going on, whether it was an immune flare,
right,
the pseudo progression,
right,
which just means that it looks worse, but it's not really going to get worse.
Yes.
But then the tumor marker in the blood, the ctDNA, made us concerned enough to get you on chemotherapy. And quite frankly, when you started chemotherapy, my biggest fear is he's going to get sick. He's going to say, no way, I don't want to do this anymore. And that everything I would have been telling him the whole time about chemotherapy, he would have said, thank God I never did it.
Yeah.
But you did well. You did well with it. You did have side effects, but what I try to have patients understand is side effects are mostly manageable.
Yeah.
It's very rare that a side effect can't be in some way alleviated.
Right.
There's lots of other things to do to support a person through that.
Right.
And most of them are temporary, right? So you've got to have a realistic conversation about how many days you're going to feel bad and then how you're going to feel on the other end of that.
Right.
So that was a success.
Yeah, it
And
was.
then I think that we lightened the chemotherapy up and then had to re-intensify.
Yes.
I don't know if you want to talk about that.
Yeah, yeah, absolutely. Yeah.
I'll also just briefly mention, chemotherapy, that's been around for
Yes.
8 decades now. Okay.
Right.
So the 50s, we had compounds that we would now look back and say that was actually chemotherapy.
Right.
These are DNA damaging agents.
Yes.
They're toxic poison, they're poisons, they're therapeutic poisons. They can either damage DNA or proteins. And that's scary to hear, right?
Yes.
What I tell people, it's kind of like, well, you got to match what you want to have an effect on with how you can do it.
Right.
So with an antibiotic, you're going to try to kill what? Bacteria.
Right.
With cancer cells, you're going to try to kill them with chemotherapy. Just it's a term for that kind of a drug. But it goes everywhere. It has no specificity.
Exactly.
And that's where we're trying to get away from. And that's why Cabometyx, which has a little bit more specificity about where it's going exactly,
Right.
we're starting to move towards those types of drugs.
Right.
But when you think about chemotherapy, it still has a place.
Absolutely.
And in fact, we use it every day.
Right.
So it's that narrow therapeutic window where if you give too much, somebody's going to really get sick. And if you don't give enough, they get no benefit.
Yes.
You got to hit the sweet spot.
Exactly.
And you don't always know in that first dose
Yes.
if you went too high.
Right. Oh, yeah.
Because of the way it's dosed. So we made adjustments,
Yeah.
neuropathy and things like that.
Right.
So
Yeah, there were side effects, but honestly, it was nothing like I expected it to be.
Anticipated.
I had such a hard time wrapping my head around this idea of I'm going to poison myself back
Sure.
to good health.
Sure.
It just didn't make sense to me. But I'm so glad that I hit it when we did, because to have that big of a swing, I feel like, it's what I needed, and then also what I had done before that, I felt like it obviously the results were great.
Right. And the dendritic, that was another component. We don't know which was doing which. You got another infusion, I think, boosters, so to speak.
Yeah, after
and
that.
So
yeah.
that ran its course for a while and brought us to late 24.
Yeah, exactly. And then now here we are. I had with the chemo and the dendritic cell thing, we got down to 0 on the tumor marker, and then it ticked back up to 18, and we were like, okay, we still see spots here. There's no way to know if those are benign or cancerous unless we biopsy or let's take it out. And we got everything out of the chest, even the stuff that was like in between ribs and everything.
Yeah.
Dr. Guajardo did a great job.
Yeah.
He worked me over real good. I told him, man, y'all worked me over in there.
Well, with the success of prior surgeries and knowing we were running through quite a bit of other therapies and your young age, another call that we had to make together, right? So do we do radiation therapy? Remember we talked about
absolutely.
that as an alternative to opening up the chest and trying something there, with the concern that maybe that surgery would not really alleviate or give us an answer that we wanted.
Right.
And that was a process of getting you ready for that.
Right.
But I'm glad that happened because it was a pretty successful surgery, but it was painful for you.
Yeah, it was. That one definitely.
Yeah.
But it was worth it because, we came off of that. The tumor markers went down to like 10 or somewhere around there. And then we started with the Fotivda
Right.
and the booster with the dendritic cell. And, things look to be pretty stable right now. The tumor markers have been right there between 5 and 10.
Mm-hmm.
That one spot that's in my abdomen wall, we didn't get that one in the surgery, but we're still keeping a close eye on that, and things have appeared to be stable. So can you talk a little bit about the Fotivda and how that, what it is and how it works?
Sure. So I mentioned earlier the TKI, that family, which is a tyrosine kinase inhibitor.
Yeah.
So it's another one of those kinds of drugs. So it's in the class of Cabometyx,
right.
but it's more specific. So it has less targets outside of VEGF. So it's a cleaner drug. It's a little bit different schedule. You take it for 21 days and then have to take 7 days off, so that it kind of doesn't build up too much. But the side effect profile is better.
Yes.
And so it got approved even in patients who had previously been exposed to drugs like Cabometyx, because it had efficacy there. And I think it'll move up. It'll move up slowly into the earlier parts of options.
Oh, okay.
So it's been a nice addition, and we just have to see how long that would work.
Right.
And then there are still other drugs to consider when that stops, or if it stops working, and then other clinical trials that are actively, being done.
Yeah, let's talk about that. I've you've kind of given me a little peek in there, just talking about how the response rates are really just increasing by like not just a little bit, like a pretty good deal, right? With these trials. Like, so let's talk about that. Like what all is out there on the cutting edge, and what are the results that kind of bring a little bit of hope to this audience?
Sure. So the nice thing about clinical trials is that really in oncology, you don't get a placebo.
Yeah.
I think people are so scared that they're going to get something that is a sugar pill.
Right.
When they hear about
Yes.
something experimental or clinical trial, but in oncology, it's always something that we intend to work.
Right.
But we need to know a little more about it. I think the immune therapy is really still the biggest area within oncology that is really going to blossom. So even though you have had immunotherapy and you've had different types of immunotherapy between the dendritic cell and the FDA-approved products, there's no reason to believe you couldn't again get a different immune drug.
Right.
So that would be an area of interest, and that will continue to be an area of interest, refining the efficacy there and the toxicity.
Right.
The other smaller molecules like TKIs are also of interest, but within kidney cancer, that probably has a little bit more of a finite amount that they can get out of that.
Right.
There's another class of drug called hypoxia-induced factor inhibitors, and those may or may not apply in your situation. We don't know because they don't get studied in rare tumor types.
Right.
But that there is a drug available already, and those pathways are being investigated. There's something called antibody-dependent cytotoxicity and antibody chemotherapy conjugates. So this is where you have an antibody, which is a protein, bound to a chemotherapy backbone. And so those are delivered. There's a bunch of FDA approvals for those kinds of drugs, nothing in kidney right now. But that's where you're targeting your chemotherapy. So rather than putting the chemotherapy in the body and letting it distribute everywhere, it's attached to an antibody that takes it more specifically to where it's needed.
That's incredible.
Yeah. So that is a very large area of research because that gets you the chemotherapy effect, which is an anti-DNA or protein kill on the cell, but don't let it go to the tissues that don't need it.
Right.
Yeah. So, at the START Center, there's 50 plus compounds being studied. And in San Antonio as a whole, there's probably close to 200 that people can potentially access on a clinical trial.
It's incredible.
And then bigger institutions have others. So, yeah, it's those are tools I'm looking forward to using.
No doubt.
When Keytruda came out 12 years ago now or something like that, that was studied at our institution initially.
Yeah.
And so we knew about it. We knew it was working. It was in melanoma primarily. And then we finally got it approved and we got to use it in the clinic like where I am.
Right.
I'm a clinician, not a researcher.
Yes.
So that's always exciting. And I experienced that in my residency.
Yeah.
Hearing about a drug that got approved that was brand new, never been done before.
Right.
And that was exciting. So it still happens.
Yeah.
And
just amazes me where this has evolved just from the time I was diagnosed in 2020. Like the Cabometyx, the Fotivda, that stuff wasn't even available yet. Like,
right.
And now we're talking about ways that you can like get chemo to run right at it.
That's right.
And it just blows my mind.
And this is what throws a wrench in the prognosis, right? So if somebody 5 years ago is to say, what is my prognosis? And they've lived long enough to see another drug.
Yeah.
That prognosis has changed completely from what you thought it was 5 years ago.
Right.
We call that kind of conditional prognosis. The longer you live,
Yeah.
probably the better your prognosis is going to be, because something new is going to come along.
Yeah, exactly.
Right. And that's the hope I think that, people can take is, if this doesn't work or the next one doesn't work, maybe there's going to be something that'll come along that can help.
That certainly was my case.
And that could be within what I'm doing or what other people are doing in terms of supportive care.
Absolutely. Yeah, you guys at the Start Center have been great to us. I mean, the whole team,
There we go.
They've been a blessing to our family.
Yes, I'm glad you said that. I work as a team, and my nurse Jerry, my MA Patty, my other MA Michaela, the front desk, the treatment nurses, the lab.
Yes.
It's a big collaboration, and a lot of times patients will obviously be focused on me or my nurse or my medical assistant, who they spend the most time with.
Right.
But there's a whole team there working through it, and we've been blessed to have such a big, team together.
Well, y'all's team is, we're grateful for the work that y'all are doing. I mean, no doubt it's a big reason why I'm sitting here talking to you today, because things were not looking good for a while. And, I'm just, like I say, I can't even begin to explain how grateful I am to be in a position where I'm coaching flag football again. I'm starting a foundation that is going to give to the cancer community, and just renewed purpose, and y'all are doing some really special work as well. All I want to say. And yeah, I think that, I hope that this episode really helps the cancer community see that, they're really good people out there that really want to make a difference in this community. Yeah. And that's certainly been our case with the Start Center. So we appreciate you very much. And, if our listeners want to learn more about you, or maybe someone wants to reach out to learn about getting treatment with you guys, how would you direct them?
Yeah, so the Start Center on Google will get you to our website. I think it's thestartcenter.com.
Okay.
And so we're all listed there. Our sites are listed there, and what we do, and that would be the way to do it. I think it's just through the internet right now.
Outstanding.
Yeah. And it's been absolutely reward for me to see you go through these years doing everything you're doing. I learned from you.
Oh,
right?
You.
I mean, patients teach us things, not just how to behave. And, patients give you feedback if you don't treat them well.
Yeah.
And that should work that way. But
Absolutely.
just, feedback from patients, and saying thank you, or saying, hey, you could have said that differently, or I'm glad we chose my way.
Right.
We learn from each other. So it's an absolute pleasure for me to see you thrive. Ups and downs, but you are really miraculous.
Well, thank you. It was not by the power of my own strength.
Sure.
That strength came from God.
Sure.
So I give all the glory to Him, and I'm just grateful. I'm going to keep listening and obeying what I get, and hey, we're going to ride this thing out, till the end, baby.
There you go.
And that's the other thing too. I'm glad to hear too that your perspective on taking pause and praying, and trying to make sure that you've made the right decision, because that's one thing that I've learned as a patient is like, we all got to go at some point, right? You never know what it's going to be. It could be a disease. I could live to be 103 and die of something else, right? But you're going to die, right? But you can't let these things take your mind and swirl it around on future possibilities and all of that. So I think that's really great to have a doctor that respects that, that says like, I'm fighting a bigger battle than this physical thing in many ways. Like the spiritual, emotional part of it is, if you don't address that, you can make some irrational decisions.
Absolutely.
So I really respect that about you guys.
Thank you.
Well, Dr. Rodriguez, it was an absolute pleasure to have you today. I really appreciate you taking the time, and hopefully we can do this again real soon.
Absolutely. Thanks a lot.
Until then, let's be golden.
Yeah. Let's do it.
All right. Thank you.
Thank you.
Thank you for tuning in to the United Creed podcast. We are a 501c3 nonprofit that provides funding for cancer patients to receive cutting-edge treatments that aren't currently covered by health insurance, while also fostering inner wellness through Freedom Prayer Ministry. I would like to invite you to go to theunitedcreed.com and donate $20 a month to our cause. That's just 65 cents a day, which isn't much, but your donation is literally an answer to thousands of prayers. Take my story, for example. My community rallied around me and raised money so that I could receive immunosine dendritic cell treatments, which isn't currently covered by health insurance. I'm happy to report that I'm in good health and enjoying excellent quality of life. And this treatment wouldn't have been possible for me without the compassion of my community. So this is what inspired my wife and I to form the United Creed. Our goal is to inspire 50,000 people to subscribe to giving $20 a month to our cause. That would raise enough money to cover 100% of immunosine dendritic cell treatments and travel for over 100 cancer patients every single year. So please go to theunitedcreed.com and click the donate button today. Together, we can bring unity and perseverance for the cancer community. I know it because I've witnessed it. So thank you, and God bless.